calcium channel blockers are super interesting drugs. They're somewhat comparable to beta blockers, not in their mechanism of action, but in their effects. If you want to learn more about beta blockers, you can go to the adrenergic videos in my neurologic section. But for calcium channel blockers, I want you to think of two major categories: the dihydropyridines and the non-dihydropyridines. Both verapamil and diltiazem are in their own class of drugs technically, but think about them as non-dihydropyridines. For the dihydropyridines, you're going to have the site of action only at the arterioles, and it's going to block those calcium channels. As a result, you'll have vasodilation, and that sounds like a really good thing for those with high blood pressure, but the problem is that the heart wants to respond. It says we're decreasing the amount of blood getting to the body because of that vasodilation, and it causes a reflex stimulation of the heart, increasing the heart rate and the contractile force. Luckily, this is a short-term effect. We only see it as a transient effect, but that's a major difference between the dihydropyridines and the non-dihydropyridines. We'll use these in individuals with hypertension. Amlodipine is the one I've seen most commonly used. And as far as side effects go, there are several, including hypotension. This happens in any of the antihypertensive drugs. Too high of a dose, too many drugs can drop that blood pressure. It can also increase the cardiotoxicity because it will change the effects on the heart, often creating arrhythmias. The most important side effect for amlodipine is systemic edema. You will often see this present very textbook, very classically. Recently started on amlodipine, mild edema on the lower extremities. It's not often pitting, but it's a good reason for individuals to have edema. These can be combined with beta blockers to decrease that reflex stimulation of the heart, but it can cause an intense anginal pain, and it can also cause more of the blockage of the heart in terms of its function, causing arrhythmias. Now down to the non-dihydropyridine. This is verapamil and diltiazem, and they're virtually the same drug. The only thing that's different is their PK/PD. This acts on both the arterioles and the heart. So it's not only going to vasodilate, but it's going to stop the heart from increasing its rate and contraction. These are used in hypertensive patients and in those with diastolic heart failure. It can suppress dysrhythmias because it actually has effects on the heart. None of the dihydropyridines can be used for any of the heart dysrhythmias, only the non-dihydropyridines. They have many of the same side effects, and their interactions are virtually the same. Beta blockers are actually going to be less helpful in this circumstance because, once again, these do block the heart. Individuals with pre-existing heart conditions that affect the AV node most commonly, including third-degree AV block, sick sinus, they should not be placed on the non-dihydropyridines. Once again, the biggest difference between diltiazem and verapamil is the PK/PD. The first pass effect is pretty heavy on both of them, and they're almost completely metabolized.